All right, so we have this 14-year-old boy. 14-year-old boy on Ciplox-D, dexamethasone, the VKC. He's come, and this is what he is. He's absolutely normal discs, but he already has 36 and 24 pressures. So I'll open it up to the panel. Yeah, what would you do? What next? The question is what next? It is steroid-induced glaucoma, and if you notice this very, very carefully, he has this inferior RNFL loss here, and you can see the RNFL, which is nice and white, and here the blood vessels are shining through, and this shows up as a small RNFL defect here with a corresponding field. So it's already glaucomatous in the right eye, and his pressures are 36 and 24.
So the first thing you are going to do with, I know Sushmita wants us to say, is that you just withdraw the steroids and then wait for some time and see whether because many a times the pressure would just come back to normal within 2-3 weeks. That's the first step. But since there is a damage already existing, and that is the thing that possibly in this situation we would withdraw and plus start treatment as well. Plus you are withdrawing the steroid. It is a VKC, so you may add tacrolimus over there, which comes non-steroidal anti-inflammatory, so that in order to settle this, plus cold fomentation, which works beautifully.
But I would like to start the treatment when there is a damage.
You would like to start treatment?
Not only the withdrawing of the steroid.
All right, but my only caveat to that is, suppose the steroid is withdrawn and the pressure comes down. So then, I mean, your damage is over.
You withdraw anti-glaucoma medication as well.
All right.
Withdraw the anti-glaucoma medications and follow this patient up and see if there is another
rise.
Yeah,
but it's been there for a year, and another, say, 4 weeks is not going to do very much damage. That's the only thing.
You can always follow this patient up because you don't think that he's going to
so Dr. Nangia, what would you do?
Said actually that we may not need to do anything more except withdrawing steroids and
no, they didn't say withdraw. They said withdraw steroids and treat glaucoma.
Yes, that's what I'm saying. You have to treat because the pressures are too high actually.
So I'll just share this. So this 25-year-old chap we had. So you've understood the variance, the two sides of the coin, and that coin is much more weighted on that side. So it's an uneven coin. What one perspective is, why don't we just stop everything? It's very, very early damage. He's a young guy. His optic disc is robust. And let's at least see how far the pressure comes down and whether he requires. But so I'll just share this. This 25-year-old man came to us. This is how he was, 624, 618. He had a cataract. You can see that. So you can see the disc hazily through it, and it was pretty much glaucomatous. He had advanced glaucomatous neuropathy both eyes. I couldn't image the other eye. He had, of course, corresponding fields, allergic eye disease. He had topical steroids for 2 years, Pyrimon, which is our biggest enemy where steroid-induced glaucoma is concerned, but he had stopped it since 1 year. And his pressures were 14 and 16 since he'd stopped it. So, well, the first thing we did was did a phaco. I mean, that's the most exciting thing about him, isn't it? So we got these back so that his vision could get back. He got back his vision. Pressures remained at 14 and 15 and disc are advanced. So now the damage has occurred. The steroids are off for more than a year. His pressures have never gone beyond 14 or 15. And I've never started any anti-glaucoma in him. Now what?
I will not worry about anything,
okay.
but I will see him yearly or 2
yes.
yearly.
Yes.
He should be in the follow-ups.
But no treatment.
He's a steroid responder, remember.
Yes, he's a steroid responder, but no treatment as yet. But management, follow-up is also management.
No, follow-up I think should be much more frequent.
Much more frequent.
Not
okay.
1 yearly. I think to begin with, I'll follow every 3 monthly.
Okay.
In India, and please remember all this, whatever we were talking, in India, if you tell them 2 monthly, they will come in 4 months. You tell them 6 months, they'll come in 1 year. You tell them 1 year, they will never come. So be very, very careful about this.
So counsel them that you are at a risk of.
So this, if you notice, and I've been honest enough, that this was 2007, and this is 11, and this is 12. So it's been 5 years, 6 years follow-up, which I've put on. He's pretty much the same. 6 monthly follow-ups, without treatment. The OCTs are only being used to just be sure, but please remember the OCT in advanced disease actually is not a very good tool to follow up, because you need to follow up by visual fields. So over-aggression of treatment, and in fact the left eye has a bit of rim left as well. So just to bring on the point that just because you see 0.8 cups is no reason to go into a frenzy and try to bring it down to 10. Because if you understand what the disease is, that this pressure was high, that this damage has occurred, and now it's all over and done with. So he's not a kind of primary glaucoma who's going to keep on progressing unless you bring down the pressures at 10. So that was the point. Yeah, please.
The only point to remember is that because he was a steroid responder, there is a very likely chance that he can even develop an open angle glaucoma in the future.
Yes.
So you have to just continue to watch him even if he remains stable for the next 7 years.
Yeah, he'll have to be on. Of course, you need to tell him that management is, you have to come back to me all your life, because I'm not sure that you're going to remain stable like this unless I do your fields and I keep this thing. So if you just partner with them and you shake their hands and then they're with you and they do come back and follow up. So here's another one. 50 years old, and he actually came on 13th, so he knew this course was on, and it was almost as if he said, okay, put me on as well. So the minute...
Another caveat that you have to write down over there and explain to him that I just had a patient like this, he was started for steroids for something else. Okay. And since they don't really correlate what is happening, and they'll suddenly become worse. So you have to tell them any new medication
that's right.
in
that's
the body,
very good point.
anywhere,
yes.
even an ointment, you tell us before you start that.
Yes, that's true. That's a very good point. Write it on the card in red letters and explain to them, steroid nahi lena. Every dawai you asked your doctor, steroid to nahi hai isme, because you have almost gone blind with glaucoma. Right, so this guy says, put me on, so I did. So blurring of vision since 3 months. Otherwise absolutely healthy, 6/6 vision, 16 and 14, normal pressures, but a very, very concave iris configuration. Patchy pigmentation, the resolution is not too great, but then there is, you can see how concave this is, if I could catch it, and very, very patchy, especially in the superior angle, and advanced glaucomatous optic neuropathy. No, so what next? I mean, what are your thoughts? This is how he presents to you. I don't need a field to say that this is glaucomatous optic neuropathy, there's no doubt. But pressure is stable, normal.
What is his corneal thickness like?
I think it was normal, 540 or nothing.
Unilateral?
No, bilateral. Bilateral glaucomas. So the clue here was, it's very tempting to jump to, this is the other eye, sorry. So it hasn't come up too well, and unfortunately he went off before I could do a UBM. So that's I wish I had that, but it was very concave, you have to take my word for it. Very, very concave. So very concave and patchy pigmentation and elderly patient. I really wanted to bring this on because there is a entity called burnt out pigmentary glaucoma. And it's well known, and it's one of the causes which are erroneously thought and labeled as normal tension glaucoma. So I think this is what he was, because in that case, there are these publications which say that since NTG is also a slow progressive thing, once you've done a diurnal and you've ruled out everything else, you could probably just monitor him, maybe get him back 3 monthly. And
can you go back to the...
Was the patient myopic or anything?
The patient was about -2 myopia.
-2?
Yeah.
Sushmita, what is the cause?
Actually, do you see anything in the iris? Iris transillumination?
Transillumination defects in PDS in our races is very difficult to elicit. I mean, we get it very, very, but then this concavity and the pigment, the concavity was very, very characteristic.
I mean, I would have
really
thought
concave.
that if there was pigmentation, first it should be inferiorly rather than first being superiorly.
In PDS, no, agreed. But in PDS, if there's superior pigmentation, that is what gives you the clue that it's PDS. Inferior pigmentation could be normal, could be physiological. It's only when it's in the superior angle that you start worrying, at least. Yeah.
Were there any gluten nodes spindles, one,
No,
and why
no.
did he complain of a diminished vision only for the last 3 months? If this has been a long-standing, PDS,
True.
then the diminution in vision should have been
There for
noticed
a long
much
time,
earlier
yeah.
than just 3 months ago. It is possible that he's 50 years, so now he's even got some lenticular changes, and
yeah.
so that is contributing to his.
And the lenticular change is what apparently they say might result in reversing the reverse pupillary block and
correct.
burning it out.
Correct.
So the idea that once everything sort of washes out, I just brought it in to just highlight that there is an entity. I don't know what's happened to him. Probably some years down the line I can, but right now I'm just taking a call that let me just see without anything. But that's one entity that is there. But it's very, very like a PDS, and I've had a couple of cases in the last few years of burnt out people coming at 60s, and once the lens is out, it washes out even more. I mean, that's what they've said. So that's just one caveat there.
One more message, that any case of NTG that you suspect, prove the diagnosis by excluding all other conditions and wait for progression before you start the treatment.
Even in an NTG, when we've diagnosed NTG, would you still wait for progression before starting treatment?
I think I will.
Okay. Dr. Harsh doesn't.
No, that's a tricky point. But if their pressure is on the higher side, maybe you are easier off treating it. If it is 14, 16, you can just wait and see, but you have to see whether the patient is compliant or not, and he is going to come back to you or not. Otherwise, these kind of discs, leaving him off by the time they come back, you may be in serious trouble. So you will have to take that call. It's not a, and I think for that kind of patient which you showed, it is only an institution where they can be really followed up regularly, and something can happen. For a general practitioner, I think they'll just be safer off putting on medication and then sending to an institute to do this kind of workup.
So this gentleman also came very, very recently. Somehow, the 72-year-old primary open-angle glaucoma, the pictures are so terrible. I wish I could, they're much better on the laptop. But anyway, he had, these discs are obviously glaucomatous, and the right is worse than the left, but the discs are not seen visible here at all. But you have to take my word that it was can we have the brightness down or something to do with the resolution? Because like, we can't see anything. Maybe this light could be switched off. Yeah, that's much better. Thank you. A little better. But can you switch off this light? Maybe it'll work, huh? The whole thing. Anyway, so, well, all right. So this is seen a little better. So this was a little more. And he was a patient who had been following up with us. The visual field was apparently progressing. So you see, these are the baseline. These are what Dr. Harsh has shown, the event analysis. And you can see there are far more black spots here. But look at this visual field which says no progression detected. So remember that the machine is not always right. So it shows you that there's no progression, but then you can see the trend analysis going really, really downward. So what next? His pressures are all right. It's not too bad. On travoprost for 3 years now. And this field shows up as looks worse, but no progression. So what would you think of? What would you do? Fine. Nicely compliant. Dr. Mayuri asked about compliance.
We'd probably look at all other causes. So you'd probably want to do his Holter monitoring, because
no, but would you say this is progression or not, even though machine is saying no progression?
We'll do the repeat fields to make sure that.
So your visual field, GPA, like they said, it will only flag progression if the same 3 points are deteriorating compared to baseline over 2 consecutive visits. So this was the first visit where we thought it was deteriorating, and that's why the machine is showing up no progression. But be very careful at just reading off what the machine shows you, because you need to know what no progression means. Probably if you do a next field, it will show up that it's possible progression, and then the third will show up likely. So that's one. So okay, so we take it as there is progression. So would you like to go back to, let's see what he was like initially?
Yeah.
And see, yeah? So we probably, that's the first thing that you would, that if you think there is progression, and this is the value of baseline investigation. What all of us keep saying, when a patient comes to you, document everything, even a disc diagram or a disc photograph or something. So go back to what you had. My slide is not moving. Yeah, it's moving over. Right. So this was the baseline. And I don't know whether it's very clear here, but the inferior notch has really dipped in. Yes. Is that noticeable to you? The inferior notch from 2015 to 2018, this was a much healthier rim, and this has really dipped in here. So the value of baseline is, even though the machine is telling you no progression or anything, your clinical sense is saying 14 pressures in the right eye for this gentleman was simply not enough, because structurally also he's dipped in and functionally he's showing a progression. This was a period when we didn't have an OCT machine, when the old one conked off, and in the government sector it takes you 2 years to get a new machine. So this was the 2 years when we used our HRT. So you can see the cup on the HRT in 2015 and the cup on the HRT now. You don't really need a machine. Your clinical diagnosis or evaluation will tell you the same thing, but the HRT makes it a little more objective, and you can see the cup is going right till the bottom, up till the rim. So this patient is obviously progressing. Obviously his IOP needs to be lower, and when you see the first, his pressures when he presented was 24. It's down to 14 now, but the value of follow-up is that 14 is not good enough for him. So anything else, Dr. Harsh, your comments on? So just the last one, sometimes we do forget this 50-year-old with headache, pressures of 12 and 14, discs are normal, left eye has a notch, so there's no question that there's no glaucoma. Your OCT is green. So answering the question of green OCT with an RNFL defect, remember, with the disc hemorrhage sometimes, with the extravasation and acute disc hemorrhages, we've seen that the RNFL around the disc might actually have a little hump. So be very careful. If you follow them up, the RNFL will show up. So despite this, remember, the gonioscopy shows occludable angles. So don't forget primary angle closure glaucoma. We have seen them with notches and disc hemorrhages as well. She does require laser iodotomy, and we can't forget angle closure in our scenario. Right, so any closing comments by anybody? Otherwise, in a nutshell, never forget gonioscopy, of course. Timely treatment, that's the crux of this course, but don't be overzealous. Set judicious targets for intraocular pressure. Be careful of variations and monitor regularly, both on structure and function. I think we'll wind up because it's 12. Thank you all for being here. Thank you, my co-panelists, for being part of the course. Thank you.